I have no disclosures for this presentation. I think most people would agree, whether you're a physician or not, that this EKG is abnormal, and I know that because it tells you that it's abnormal right at the top there. But if you see this EKG, one of the first things that you're going to do is you're going to grab for calcium. And the reason that we do that is because it decreases the depolarization effect of an elevated potassium level. Now the question is, when should we be using calcium? If you see an EKG that looks like this, and the next step is a sine wave, of course we're going to be giving calcium in this case, and there is data to support this. What about in the middle of the road EKG, where potassium level is quite high, you have some peak T waves? In this case, if I look at the literature, I always give this, but probably is the right answer, but we always do it. The question comes up to, what do you do if the EKG is normal? Now, there are some cases of a normal EKG with pretty high potassium levels, so it's not completely a great sensitive marker, but in this case, maybe is the answer. And a lot of people would say if the EKG is normal, then I don't need to give calcium in this case. What dose do we give? Well, we don't really know. The literature says that probably 1 gram of calcium chloride or at least 2 of calcium gluconate would be sufficient. One thing to note is that this doesn't last very long, so you may find yourself needing to give another dose of calcium, maybe 30 or 60 minutes down the road, depending on when you're able to get that dialysis arranged, if that's the right next step. What I really want to talk to you about today, and the teaching point for the calcium, is this. We all know that calcium chloride contains more elemental calcium than gluconate, so in order to get an equal amount, you need to give 3 times the volume with calcium gluconate. But what a lot of us were taught is that calcium gluconate takes longer to start working than calcium chloride because it needs to undergo some sort of hepatic activation or metabolism. But I want to show you why that's not true. This is one of my favorite studies of all time. They took patients that were undergoing liver transplantation, and in the phase of the transplant where they had no liver, they gave half the patients calcium chloride and they gave half the patients calcium gluconate, and they measured ionized calcium levels for the next 30 minutes. And what they find is that regardless of which salt you give, there's an equal and fast rise in the calcium level. And what that means to me is if you don't have a liver, then it probably doesn't need to be involved in converting calcium gluconate. If this study wasn't enough, there was this really weird study that they conducted in both children and dogs in the same study. And they basically looked at the same thing. They looked at calcium chloride versus calcium gluconate and how quickly it raises the ionized calcium level. And they found again that there was an equal and fast rise in the ionized calcium level regardless of which salt was given. If that was enough, there was a third study that was in ferrets and in vitro human blood that again found the exact same thing. So what I take away from this is that whether you don't have a liver, you're a child, you're a dog, you're a ferret, you can give calcium gluconate or calcium chloride and you're going to have the same result. So what I say to you is pick the one you like the best, or whichever one is not on shortage at your hospital at this current time. Just make sure that if you are giving calcium gluconate, you give a little bit more. We start with 2 grams at my hospital. A question that I frequently get asked is, what about the calcium chloride in terms of giving it through a peripheral IV? We avoid that issue by diluting it in 100 mLs of saline, which I know is also on shortage. Okay, the other major treatment for an elevated potassium level is insulin. And when you give, most of us would give a 10-unit dose of insulin. It seems to be a standard dose. When you do that, it drops the potassium level by about 1. The problem, though, is not the insulin dose that we're giving. It's that we significantly don't recognize the hypoglycemic effect of that 10-unit dose of insulin, especially for patients that start with a normal glucose level. So I want to walk you through how I manage this. If you look at the studies, it's just like any time you look at studies, there's a range of hypoglycemia anywhere from like 8% to 75%, which is completely useless. If you really boil it down to the good studies, it seems about 10% of our patients get hypoglycemic after we treat them with insulin for hyperkalemia. This is such an important issue that the Institute for Safe Medication Practices just recently in February released a safety alert that highlighted all of the errors that happen with insulin when we're treating hyperkalemia, and this is one of them. Why does this happen? Well, if you look at IV insulin, it starts to work, the IV regular insulin. It works in about 5 to 10 minutes is when it starts. It peaks at about 25 to 30, but it lasts about 2 to 3 hours. And if you contrast that with the dextrose that you're giving, that only lasts about 30 to 60 minutes. And if you look at all of the studies and when these patients actually got hypoglycemic, it was about 60 minutes after that insulin dose when the dextrose was wearing off. So how do we avoid this? And what are the risk factors? None of these are going to be very shocking to you, but the data that looked at what puts patients at risk for hypoglycemia is patients that don't have diabetes to start, so that probably means they have a normal glucose level. And a lower glucose level to start, again, these are all from the same study. Renal disease, which most of the patients we're treating for hyper-K do have some degree of renal dysfunction because they clear the insulin a little bit quicker. And then obviously an increased insulin dose. So the higher the insulin dose that you give, the more likely your patient is to develop hypoglycemia. None of these are earth-shattering. So how do we fix this? The most frequent problem that I see is that when we look at our hyperkalemia order sets, they pair 10 units of IV insulin with 25 grams of dextrose, or 1 amp of D50. But that's frequently not enough. So here is the way that I approach this, and this is loosely based on the published RUSH protocol. So if their glucose level is normal to start, then they need at least 2 amps or 50 grams of dextrose to start, and they need Q 30-minute finger sticks for the first hour, and then hourly up to 3 hours. If their glucose level is a little bit elevated to start, then you might be able to get away with just 25 grams of dextrose, but again, you need frequent monitoring, at least hourly for the first 3 hours. If their glucose level is over 200 to start, you may not need any dextrose at all, but you could also just give them a 1 amp or 25 grams. In this particular situation, I'm more worried about hypoglycemia than I am about transient hyperglycemia. So this is the algorithm that I use. So just to sum up, if you have EKG changes, give calcium. It doesn't matter which salt you give. Both calcium chloride and calcium gluconate are equal in their ability to raise the calcium level quickly. Anticipate hypoglycemia and make sure you look at your order sets when you go back to make sure that the dextrose dose is high enough to avert hypoglycemia. And I thank you for your time.